Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, my name is Ruben Mesa, and I'm the president of Atrium Health Levine Cancer, the executive director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center, and excited to join my wonderful colleagues, Dr. Mascarenhas and Bose, today for today's conference briefs, highlighting myelofibrosis clinical data from key conferences ASCO, EHA, and SOHO from 2023.
So I'm going to cover emerging novel agents in myelofibrosis as part of this conference briefs program, where the three of us are reviewing the myelofibrosis abstracts from ASCO, EHA, and SOHO of 2023. So this is a listing of many of the agents that are currently in development. There are certainly more, but as you can see, there's a whole slew of different pathways being targeted, as are shown here. We have monoclonal antibodies, small molecules against all of these different targets, and on the right you can see their phase of development currently. So clearly a very exciting time, with many of these agents having been touched on at these three meetings. So we'll start with luspatercept, which of course is not new and is a drug that we actually can use today, albeit off-label, for our patients with myelofibrosis and anemia, since this drug is available, as you know, for MDS and beta thalassemia. So this was a phase 2 trial that was done in myelofibrosis with 4 cohorts, as you see on the left up top. The patients could be either on a stable dose of ruxolitinib or not on ruxolitinib, and they might also be transfusion dependent or transfusion independent. There was actually not room in this trial for transfusion requiring patients. You either had to be transfusion dependent by formal criteria or not needing them at all. Now, so again, 4 cohorts, 95 patients total, and what this particular abstract at ASCO was focusing on was really the safety, as you can see here. The results of the efficacy from this trial has been presented a few times, and we know that the signal of greatest efficacy seems to be in the patients on ruxolitinib, particularly those who are requiring transfusions on ruxolitinib, but also those who are not. But what you see here is the safety. So you see some hypertension with this agent, you see some diarrhea, there is some limb pain, bone muscle pain that can occur shortly after the injection, but overall a very well tolerated drug. Now here is the efficacy. I alluded to this a little bit. Here you see the upper panel is for the primary treatment period, which would be the 24 weeks, and then the entire treatment period down below. As you see, again, 4 cohorts, and those are defined up there for you, Rux or no Rux, transfusions or not. And as you see, again, cohort 3B is really what stands out, although cohort 3A is also a little bit better than say cohort 1. So again, patients with Rux or on Rux requiring transfusions or not seem to benefit more from luspatercept, and this agent is now being developed in a phase 3 trial in patients on a stable dose of ruxolitinib who require transfusions. That is a placebo-controlled trial called Independence. Now, moving on to naftamadlin, this is an interesting agent. It's an MDM2 inhibitor, small molecule. There were 2 studies actually presented in the same oral session at EHA. This first one was presented by Pankit Vachani from UAB. This shows naftamadlin as a single agent, and we're looking here at survival, one of the more compelling aspects of this presentation. Again, this particular trial of single-agent naftamadlin in JAK inhibitor relapsed or refractory myelofibrosis has been presented before, but what they were trying to do in this presentation is really focus on the longer-term survival outcomes. So as you see here, very impressive, obviously. This particular graph is pertinent to the naftamadlin 240 milligrams on days 1 through 7 on a 28-day cycle. It's on that dose. There were other doses that were evaluated, other doses and schedules. But even if you took all comers, the median survival was 35 months in this JAK inhibitor relapsed refractory population. But particularly on this slide, what you see is that the median survival was not reached. And this is for the 240 milligram days 1 through 7 Q28 days subgroup of patients, which is really the go forward dose for this drug. Now this development strategy for this agent has actually been shelved subsequently, and it's no longer being developed as a single agent, which brings us to the very interesting abstract that John presented at the same oral session at EHA, where naftamadlin was added to patients having an insufficient response to ruxolitinib. So one of our add-on strategy trials that we've become familiar with in the field. This is a relatively small trial, as you see 24 patients shown here. You see the baseline characteristics on the left, on the right are the treatment emergent adverse events. So if you look at the baseline characteristics, this is a patient population with fairly large spleens, 2,000 plus. The symptom burden is reasonable at 15. 10 is often a threshold for these things. Platelets are pretty good. So this is in general not a cytopenic population where a drug like this would be hard to add, but the results were actually quite striking. This showed 32% for both spleen and symptoms. So again, when I say that, I'm of course referring to SVR35 and TSS 50 at 24 weeks. Both of those were 32% in this add-on study, albeit small number of patients, but pretty good actually, among the best for what we see in the add-on setting for partner drugs of different mechanisms of action. John, comments on this? Clearly, one of the more promising strategies.
Yeah, I agree. I think the ability to combine this MDM2 inhibitor to Rux in order to restore that response was quite obvious here, both from a spleen and symptom perspective. And these are patients who sort of maxed out their benefit on single agent Rux. So I was encouraged by this data, and I think the developmental pathway for this drug is best in this setting where you're adding it and improving upon a response that's inadequate on ruxolitinib.
Absolutely. Ruben, any comments?
I think that the add-on strategy is going to be, the most attractive. I clearly realize that there have been several that have gone to the upfront approach to try to get approval and see the strategy, but that's not how physicians think. For physicians have used, single agent JAK inhibition, for the last 12 years, and I think, likely doubling or more the expense of upfront therapy. I think we're going to probably see more maturation of data than we've had up to this point from the phase 3 trials to really get a sense of, who should have kind of combination therapy from day one. But I think the addition of therapy to suboptimal responders, I think will become much more stringent. 3 months you're not having good enough response. Should we add something else in? So I think there's going to be a lot of competition in this, what's good to add on space, and this has a very interesting mechanism of action, based on, a range of things.
Absolutely. Thank you. All right, so now moving on to pelabresib, but in ET. So, of course, a lot of the attention on this drug is in the context of MF, but there was actually a trial presented by Francesco Passamonti on 20 patients actually using this BET inhibitor from MorphoSys in ET. So you see the results here, 20 patients, so small trial, early results, obviously the first results on pelabresib in ET. Now, ET is a little bit of a difficult area to develop a drug in. For example, it's not clear that the platelet count has much to do with thrombotic risk, for example, and that's one of the confounding factors in this disease when you try to develop a drug or design a trial. But what you see here is that you're also getting a nice reduction of the white count, which has been correlated with thrombotic risk. Besides the platelet count, which you would expect a BET inhibitor to reduce. There was also some symptom benefit, and you see that towards the bottom in the 14 patients where this was evaluated. So more to come on this, and look forward to future iterations of these data. Now, there was also data at these summer meetings on Manifest, the original trial of pelabresib in myelofibrosis. So this was presented from Marina Kremianskaya, who works with John at Mount Sinai, on the add-on arm. And we were just talking about the add-on approach, how important that is in the context of naftamadlin. So pelabresib, which of course has been in a phase 3 pivotal trial in the frontline setting, has also been looked at in the add-on setting. So what we are seeing here from Manifest, this is 85 plus patients, is the spleen volume change over time in the Manifest arm 2, which again is the add-on setting. And what you see here is that the spleen response rate gets a little bit better beyond 24 weeks, at which point it is 17%. But after that, you see at week 28, it is at week 48, it is 21%. So this speaks to some of the durability there. Now, Claire Harrison had presented arm 3 of Manifest. Again, the Manifest was the open label trial of pelabresib with 3 arms. There was a monotherapy arm 1, there was an add-on arm 2, which we just talked about, and there was a frontline combination arm, that is arm 3, which then informed the Manifest 2 trial, which was the large, big phase 3 placebo control. So what you see here is, again, spleen volume change over time in Manifest arm 3. Now here, of course, the 68% spleen response rate at 24 weeks has been much talked about. It's clearly a much higher number than one would typically expect with Rux alone. And what you see here is what happens to that over time at 48 weeks and 60 weeks. So it drops off a little bit clearly, but I think what you see here is that we're still maintaining SVR35 rates that are higher than what one sees with Rux alone. Now, this is about selinexor. This is an interesting drug, familiar to our viewers from its approval in myeloma and some types of lymphoma. This is what is called a selective inhibitor of nuclear export. And so this drug actually has been studied both as a single agent, not shown here, and with ruxolitinib in this trial called Export MF034, which is now entering the phase 3 portion. It's the same trial. What we are showing you here is data from the phase 1 portion. So 24 patients, 14 of whom received selinexor 60 milligrams once a week, and the other 10 received 40 milligrams once a week. And again, these data have been presented a few times, I believe, at prior ASCO and ASH meetings. But what was shown at this recent ASCO meeting, as well as at SOHO, was really looking at different looking at the data by different types of stratification, and what they really were able to show that even in patients with really low doses of Rux, which we do not really consider very effective, for example 5 BID, you still saw selinexor making a very important contribution there, and really this maintenance of the spleen and symptom response rates, despite that very low dose of Rux. And similarly for gender, similarly for different categories of spleen volume, these responses were maintained. Now, I should mention, just to put things in perspective, that with the caveat that this is a very small number of patients, 14 receiving 60 milligrams, 10 receiving the 40 milligrams, these are the highest response rates we've really seen in the field in these combination approaches. So this is just again a breakdown of those responses by these different categories. Now, Ruben, let me ask you this: since you led some of the comfort trials, for example, and other JAK inhibitor trials, what is your take on this female-male distribution of responses?
Well, we typically have not seen differences by gender, so again, don't know whether this is just happenstance in terms of this particular study. So overall, our phase 3 studies, of which we now have a fair number, we really not see gender play a big role. So not sure yet, although, selinexor has a very interesting mechanism of action. So, perhaps there's something more specific to the mechanism of action of the drug.
Sure. And also, I guess the main point perhaps is the bigger takeaway might be this low dose of Rux, which selinexor seems to be able to complement. John, any thoughts on that?
Yeah, I mean, I think it's interesting. We saw the same phenomena with naftamadilin. You could actually get the synergy at low doses of Rux with the combination partner while minimizing toxicity. I think what's interesting here is we're looking at 40 and 60 milligrams. This is once weekly, so this is not the doses that's used in B-cell malignancies. And as you point out, even though it's a few number of patients, the responses are quite dramatic, and even in the setting of low dose Rux. So I'm anxious to see how this plays out in the greater phase 3 study.
Absolutely. Thanks. And then this is a small study that we're doing at MD Anderson. This is an investigator-sponsored using a drug called elotuzumab, again familiar to our audience from its use in myeloma. So this is the anti-SLAMF7 monoclonal antibody. There is data preclinically suggesting that monocytes are the precursors of fibrocytes and therefore are ultimately responsible for the bone marrow fibrosis in this disease. And SLAMF7 is a target that one can utilize to try and deplete that population of monocytes that gives rise to the fibrocytes and ultimately the fibrosis. So this is a small study, 15 patients. 12 I presented on 12 at the EHA meeting. You're seeing some of the baseline characteristics here. I'll just briefly mention that we've seen some responses in different parameters actually. So symptom responses, we've seen certainly anemia responses, and we've also seen platelet responses. So it's interesting, and perhaps like many other things, deserves ultimately a place in a combination approach, but we're not there yet. And this is a monotherapy trial, single center, like I just said. Mylox-1 was a trial of a drug called GB2064, and the target is lysyl oxidase-like 2, which is an extracellular matrix enzyme. So blocking it, again, could be an anti-fibrotic strategy. Very preliminary results at this point here, presented by Claire Harrison at EHA. But what you're seeing on this slide is 5 individual patients and what happens to their bone marrow fibrosis at different time points. So reticulin collagen as shown. So again, very early results. We'll see what happens with this, but again, another novel anti-fibrotic strategy. Now, Ropeg, which is, of course, on the market for the last 2 years in the US for polycythemia vera, is being looked at in early myelofibrosis. So this is a very practically designed trial where they enrolled both pre-fibrotic primary myelofibrosis, which, as you know, is a pathologic entity, and also patients who could be deemed to have clinically early myelofibrosis, even if it's pathologically overt. or post-PV or post-ET. So those patients all received ROPEG. This is a trial that I think is very helpful as we sometimes use this drug off-label for our patients with early myelofibrosis. 62 patients here. So as you can see, it was clearly active. You see responses at 24 weeks in the hemoglobin, white cells, and platelets in the 70-80% range. Now, these are mostly patients who were started early on after diagnosis, 5 months, median time from diagnosis to treatment. Baseline characteristics are shown towards the bottom left, or actually all along the left. And then you see some JAK2 allele burden reductions, obviously always of interest with an interferon product. BMS 986158 is a BET inhibitor. Again, pelabresib has generated enormous enthusiasm for this mechanism, and there are multiple companies studying their BET inhibitors. This is one of them. This was presented by Haifa Ali at EHA, and you see here interesting design where the drug could be combined with RUX in frontline patients and with fedratinib in second-line patients in the same trial. So again, you see the SVR rates at, this is SVR 35. So these are bona fide responses. SVR 35 at 12 weeks, SVR 35 at 24 weeks. And you see some pretty high responses here with this BET inhibitor in combination with JAK. What was absent from this presentation, however, was any results on symptoms. And we shall see, hopefully we'll get that at a future presentation. But clearly, spleen response is looking very good. And this is another very novel and interesting compound, TP3654. So this is a PIM1 kinase inhibitor. There have been other PIM kinase inhibitors, but this is a very intriguing one thus far with early results at both ASH last year and then EHA, as I'm showing you now, as well as at ASH 2023. So what we see here in this monotherapy trial in patients who've previously received JAK inhibitor or are not candidates for JAK inhibitors, the majority having received prior JAK inhibitors, what we're seeing here is a clear symptom signal. There is some SVR 35, but clearly the TSS 50 is more impressive. And again, there seems to be a correlation, albeit early small numbers of patients, with cytokine reductions. So very interested to see what happens there going forward as we are able to correlate these cytokine benefits with the symptom improvement. John and Ruben, thoughts on this? This is very unique and novel.
I was also interested in this abstract and the development of this drug. I mean, what's probably most eye-catching is these symptom improvements. Symptom improvements are quite deep with this PIM1 kinase inhibitor. And the PIM1 or PIM kinase inhibitors have been evaluated previously in this field and have really been plagued by myelosuppression. Particularly, they've been used in combination. And here, we're seeing an agent that has clinical activity and less myelosuppression than you would expect, which really, to me, makes it a really ideal combination partner. So I look forward to see how this drug develops, in the future as a combination with a JAK inhibitor.
Yeah, I would agree wholeheartedly. I think first, the mechanism of action, I think, has always lent itself to combination approaches. And two, as we saw from the combination phase 3 trials and other things, deepening the symptom response, has not necessarily been something we've seen with the new agents. So I think this almost kind of screams out, further combinations with other things. But I think it'd be really helpful to have in the mix, and it seems to be fairly benign as well. And that's always a key thing as well. What is the benefit you get versus the toxicity? So the less toxic, the more benefit, the easier really a clinical case.
Absolutely. Yes, indeed, symptoms have been hard to improve over Rux alone, and the tolerability piece, very important. Absolutely. And here is zilurgisertib. I think Ruben had alluded to this briefly. This is an ALK2 or ACVR1 inhibitor, which is being studied both alone and in combination with ruxolitinib. That's what the two treatment groups represent. TGA is monotherapy. TGB is in addition to a stable dose of ruxolitinib. This is data that I presented at ASCO and EHA. Essentially, there were patients who were transfusion dependent as well as those who were not, but were clearly anemic. And what we've already started to see in this study is responses in the anemic patients, not yet in the transfusion dependent patients, but absolutely in the non-transfusion dependent anemic patients to this ACVR1/2 inhibitor, both alone and in combination with ruxolitinib. It is also a well-tolerated drug. The 600 milligrams is now being evaluated. These results, however, are on the lower doses, 200, 400. There's nice reduction of hepcidin as well, which is the mechanism of action. So that is a proof of principle. It's reducing hepcidin in a dose-dependent manner, and it is a well-tolerated drug. Some alopecia at high doses, but that's really at the 600. And this is also a BET inhibitor. As I said, multiple companies are studying their BET inhibitors. This is called INCB 057643. And this is also a study with multiple cohorts. It was studied alone as well as in combination with ruxolitinib. So dose escalation is ongoing. What you see on this table are the monotherapy doses 4, 8, 10, 12. Now, this part has been completed actually, and 10 and 6 are the go-forward doses for the monotherapy based on the patient's baseline platelet count, with the 12 milligram running into some DLTs. For the combination, as you see here, that's a bit behind in the development. That is, the 4 milligrams combination has been cleared, and further escalation is ongoing. So again, an interesting drug, clearly a proven mechanism of action at this point, and we'll see what is next with this drug. But the monotherapy dose escalation is complete. And that will be all. Again, that was not all the drugs being developed, but quite a few of them. And hopefully that was a good, quick though overview. Thank you all for joining us. Thank you, John and Ruben, for your very insightful discussions earlier on in the program. And thank you to our viewers for listening.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.